growth hormone IGF-1, we all know, plays an important role in overall bone growth. But what about mineralization is a question from that regards. So growth hormone increases calcium absorption and phosphorus absorption from the kidneys. And this is important because this is used for treatment of hypophosphatemic rickets, where the phosphorus absorption theoretically goes up. So your serum calcium and phosphorus is going to be more. The second thing it is going to do is to act on the osteoblast to increase the formation. So osteocalcin, which is a marker of bone formation, goes up when you give growth hormone, along with alkaline phosphatase and N-terminal collagen. So we talked about that as markers of bone formation. Now, growth hormone also produces IGF-1. So the action is not just of the growth hormone, which is the endocrine effect. It also is producing IGF-1, which is going to work there and cause greater growth. And the major binding protein here is IGF-BP5. So here, this is more like a paracrine effect. So we talked about IGF-BP3, which is mainly in the circulation, BP2, which is in the brain, BP5 is the major one in the bone, which is sequestrating this one from that regards. So in growth hormone deficiency, theoretically, you will have low bone mass, and acromegaly, you will have high bone mass. But when you give growth hormone and you do a DEXA scan and you find that the bone density has increased, is there anything that you need to worry about before you make a claim? So you did a DEXA scan in 100 children and you found that, okay, after treating with growth hormone, the bone mineral density increased from minus 2.5 to minus 1.5 SD score. Do you think this is the right depiction or some other thing you should also explain? So what is happening when you're giving growth hormone? Bone density is reportedly increasing, but what is definitely increasing is? What is the major effect of growth hormone? What is the major effect of growth hormone on bones? Size or density? So if the size is increasing, what will happen to DEXA? So you may be falsely doing that. So if you want to look at the actual effect of growth hormone, you have to look at volumetric bone density, or you correct it for size, or at least correct it for bone age, because we know as the bone age increases also, there would be a change in terms of the actual density which is there. So these things may be effective. So growth therapy, importantly, is not very clear, but people say there is a biphasic response. Initially, you will be decreasing it because your whole process is becoming active. After 6 months, there could be an increase on that. But whenever you report, when you see a study which say that there is an increase in bone density, which is aerial, DEXA based, be questioning in that regards, whether it's really a true increase in density or is it because of the impact of the size. Now, thyroxine, we discussed very well that there is T3, which has got a direct effect. Again, T3 major effect is on the growth plate. What does T3 do to the growth plate?
It fuses the fusion.
So which zone of chondrocyte does it act?
It acts on the resting zone, and then it acts on the proliferative zone.
So it converts resting into proliferative, proliferative into hypertrophic, and then apoptosis. So the whole process is accelerated. If, let's say, I'm saying it takes 1 year for the chondrocyte to become mature, it will happen in 9 months. So that's why bone age is increased in thyrotoxicosis. But what about bone? So T3 is now acting on the osteoblast as well, causing osteocalcin, IGF-1, ALP, and it's also acting on the osteoclast. So what's basically happening here? The bone turnover is increasing. And the immediate effect of increased bone turnover is? And bone loss. Because formation is difficult. They are making it up, but that has been taken off very quickly. So any increased bone turnover state will lead to low bone mass with hypercalcemia. That will be the scenario. Now, T3 also decreases the calcium absorption. So the serum calcium theoretically may go down. But we have seen so many hypothyroidism, we haven't seen hypocalcemia in most of them. But the subtle differences will be there. So thyrotoxicosis, whether it is, as I said, a primary cause or even hypothyroidism, we are over-treating. So people say, okay, 0.2, 0.1 TSH, why are we bothered about? Bone can be affected. And the only reason you treat subclinical thyrotoxicosis is this low bone mass or atrial fibrillation. These are the only two indications you treat them. Hypothyroidism, the turnover is completely gone. So it's very slow, and we have seen what happens to the growth plate, what happens to the bone overall. Now, PTH, of course, the name itself is that it is a major regulator of the bone overall. The PTH, of course, will increase the intestinal absorption of calcium via calcitriol, but it will decrease phosphorus by causing phosphorus excretion. So therefore, you will have hypercalcemia in the serum and phosphorus will go down. But that calcium is not getting deposited in the bone. It is actually taking off the calcium from the bone. So the net effect on the systemic circulation is increasing, but the effect as far as the bone is concerned is not positive. It is decreasing from that regards. Now PTH, now this is often where people get confused. PTH increases bone resorption, but its primary action is at the level of the osteoblast, not the level of osteoclast. So PTH is then going to produce lot of paracrine factors, and an important mediator here again is IGF-1 BP5 and interleukin 6 to cause bone formation. So it is also causing bone formation, but indirect effect is causing bone resorption. So hypoparathyroidism typically will again be, so hypoparathyroidism will have a low bone turnover, hyperparathyroidism will have a lower bone mass, which is there. And treatment has got again a variable effect. So what is the effect of PTH treatment on bone mass?
How we give it intermittently in bone formation and continuous will result in bone resorption.
So if you give intermittent therapy, it would actually be good for the bone. So that's why you give daily PTH. If you give it in a continuous fashion, you will basically cause bone resorption. Can you think of any other hormonal therapy? If you give it intermittently, is going to increase the hormone, but if you give it continuously or daily, it may be worse. A specific hormonal treatment. Leuprolide, you can say leuprolide, but that itself is a different thing altogether. It's anyway inhibiting. So what I'm saying is that when you give it intermittently, it is increasing the target hormone. But when you give it daily, the target hormone becomes less. That is why you give that drug every 3 days. Used very often. A hormone which is given bi-weekly. Yes, so if you give gonadotropins daily, it is desensitizing the gonads, but if you give twice weekly, you will have a better outcome. So that is important. Similar factor is happening here. Now calcitriol also, so PTH calcitriol, these are the major regulator of serum calcium and bone mass. But the effect of calcitriol again is very, very interesting. So calcitriol has a variable effect. When you have enough vitamin D, it is going to say, okay, let's make bone. So it will be causing osteoblast effect, but in deficiency, it is going to take off the calcium from the bone to the blood, causing bone resorption. It, of course, is the major determinant of calcium absorption and phosphorus absorption as well. So if you have vitamin D excess, what is the hallmark of, and how do you differ that from PTH dependent hypercalcemia to vitamin D related hypercalcemia? The most important factor is, so phosphorus levels will be high here. That will be a classical scenario. And similarly, if you go the other way around, if you have hypoparathyroidism, PT phosphorus will go up, vitamin D related phosphorus will go down from that perspective. So calcium, phosphorus, both will be high. The most notorious drug which is going to cause osteoporosis is steroids. And this could be endogenous steroids, exogenous steroids, pharmacological therapy, inhaled, oral, topical, everything. What do steroids do? So cortisol does everything which is bad for the bones. First of all, it is going to basically decrease the proliferation of osteoblast. RUNX2 and BMP2 pathways go down. And in the long run, it is going to apoptose the osteoblast. So it's going to really be bad for the bone. So bone formation is less. Second, it is going to increase rank ligand and decrease osteoprogerin. So your osteoclast will be more. Thyrotoxicosis, there is increased bone formation and resorption. Cortisol excess, formation is less and resorption is more. So which one will be worse? So clearly here you have so many factors. So thyrotoxicosis is also a cause of low bone mass, but you don't hear that many fractures in thyrotoxicosis because there at least formation is also going on. It's not as fast as your resorption, but still it's going on in that perspective. It's also going to cause calcium loss from both the intestine as well as from the stomach. The intestine effect is largely mediated through the how does cortisol decrease the intestinal absorption?
Inhibits the calcitriol level. It inhibits the 105%. Decreases
So it is through the calcitriol level that you will find that. And of course, we know that steroids are going to cause hypercalciuria. And that is why it can often cause to nephrocalcinosis if it is a long-standing treatment from that perspective, which becomes important. So it is going to have a multiple effect from that regards. Calcitonin is a minor player, both for calcium as well as bone, but it is again an anti-resorptive agent. So what does it do? It will going to decrease the reabsorption of calcium. It is going to act and inhibit the osteoclast activity, but this is transient and it will have tachyphylaxis. It also has an effect on, it's basically going to decrease your level. So it's going to decrease your calcium level from that regards, and it's a good drug as far as the transient management of hyperparathyroidism. What about sex hormones? And this is a very, very interesting scenario. So we have got three hormones which are there: testosterone, DHT, and estrogen. And there's a lot of debate as to which hormone is going to play a role at what level. And that becomes very, very important. So if suppose you have to evaluate in males, you want to know whether it is testosterone, DHT, or estrogen produced by aromatization, which one is causing bone growth? What will be your experimental design? How will you make sure that?
Follow boys as well as girls for
No. Within the particular, I'm not talking about just the humans. You can use other models as well. Or let's say genetically, humans who have mutations, you can use them. So what mutation will tell you what? So first you want to know that testosterone is working, or DHT is working, or estrogen is working. So you can use aromatase inhibitors, or you can use the aromatase knockout individuals where the effect of estrogen is gone. Second, you can take people where you use an inhibitor of 5-alpha reductase, or because the androgen receptor will cause a problem. So 5-alpha reductase inhibitor you have to use. And third, you have to use something which can block testosterone production. And then you can use a non-aromatizable androgen. If you use a non-aromatizable androgen, then you will know the direct effect which is independent of estrogen. So based upon that, a lot of studies have been done in that regards. So testosterone is a pro-hormone. I've always talked about that. It can be aromatized to estrogen, which we all know. For females, there is no confusion that estrogen is the major regulator from that regards, which is an anti-resorptive agent. It increases the OPG activity, decreases MCSF, and it is going to have a bad effect on the osteoclast. It also is going to increase the osteoblast, and it is also decreasing the inflammatory. So estrogen is very well good for bone. There is no confusion about that. So it is also going to increase cortical thickness. So in females, no confusion. But in men also, it is now known that it is the locally produced estrogen, which is also the major mediator. Because aromatase knockout mice and aromatase deficient human and estrogen receptor deficient human, they presented with tall stature, normal pubertal development, open epiphysis, and low bone mass. So which means you have got a normal testosterone, you have a normal DHT, you have got a normal androgen receptor, still the bone mass is low, which means estrogen is playing a role also from that perspective. But there is of course also a conversion of DHT And DHT is acting via the androgen receptor, and it also plays a role in certain areas. So it's not that everything is through estrogen. There are also DHT dependent effects, particularly on calcium absorption and phosphorus absorption. What do you expect the bone mass in androgen insensitivity?
Bone mass will be good, sir.
Is good. Compared to whom?
Compared to
A female or a male?
aromatase deficiency or other.
No. Complete AIS versus a normal female versus a normal male.
In comparison to the normal female, the bone mass should be higher in cases.
Yes, and males?
Male, it's the same, the higher bone mass is the same.
Beyond a level, estrogen is not going to work. It's going to work till a particular level, but you don't have any androgen mediated effect. So compared to a female, they will have higher estrogen levels, so that way they are working better. But after a level, that estrogen level is going to saturate off and don't work. But in boys, you have an additional DHT effect also happening, which I'm speculating. I'm not saying that's the main cause. That's why the boys have a larger amount of bone content. So you have got two hormones which are going to help you out. Maybe this is minor factor. So AIS, if you play, so they are XY individual, XY AIS, XX will be lower and XY males will be slightly on the higher side. What about the height?
Height, CIS will be higher, taller,
So taller compared to girls, but what about boys?
not that tall.
So generally they are slightly on the lower side. So same thing. So bone and tall, both the things are there. If you have too much estrogen, the bones will fuse early also.
Testo is not converted to BS, but the BST and testo both are not active. We converted to estrogen more.
Yes.
That's why we can have gynecologists in.
Yes.
Yes. If so, estrogen level will be higher in certain.
So estrogen levels are higher, but beyond a level in the bone, there will be a curve, sigmoidal curve.
Yes.
After that, there will be no particular benefit. So estrogen effect will be more as compared to the girls. For boys, already the local production is there, which is going on anyway in all the boys, plus DHT is also there. So that DHT part is lost. So this you have to now look into more research and tell me, how do you compare these three groups? AIS, normal female, normal male. There must be studies on bone density. You should look into that from that regards. So sex hormones, basically what is known is that DHT has a significant impact as far as the cortical thickness is concerned. So boys also have a thicker bone as well from that regards. So if I summarize, growth hormone is acting by the growth hormone receptor to have a positive effect, more formation, less resorption. Calcitriol has a dual role. It can both increase or decrease. But if you want one thing, I'd say it is going to increase. So if you make high level of calcitriol, bone will be better. Cortisol is of course bad. It is decreasing formation, increasing resorption. It is a negative hormone. Testosterone has a beneficial effect. Estrogen also has a beneficial effect. What about insulin? We have not talked about insulin. Insulin is an anabolic hormone, so insulin will be beneficial. But if you have insulin resistance, theoretically, there may be an issue in terms of the bone density. If you have too much fat, it overwhelms the cutaneous capacity, it gets deposited in the liver, in the muscle, and also in the bone. So that is one area. We all talk about normally that if you are obese, your bone mass is more, you are doing better. But studies have shown that obese individuals tend to have higher fracture rate, probably because the bone is stronger, but the load is even more stronger. So you are good enough compared to a 60 kg child. Your bones may be more, but that are not fit enough for 100 kg. So that is the discrepancy. One of the mechanisms which people say the bones actually are weaker also is because they have got more fat in the bone directly. That could be a scenario. So if you now look at how obesity has an influence in terms of bones, so there are things which can be positive or negative. We know that in obesity, the growth hormone levels are low because it's a growth hormone sensitive state. So that is negative. You will have lower level of calcitriol because your vitamin D is being used up. Fat periphery is storing it. Calcitriol levels are low. cortisol is high. We know that you have a higher hypercortisolism which is happening. On the contrary, you have got higher levels of estrogen because of the peripheral aromatization. So that can have a balance. So people have got varied results, but general picture is that if you look at the DEXA based density, it may be higher. If you look at volume, but if you correct it for height and weight and age, it may be same. What about volumetric? There may be some issues in terms of bone strength. What does undernutrition do to bone?
Nutrition will also decrease the bone mineral.
Through what mechanisms? So think about all these hormones.
In the stressful conditions, cortisol will be high.
So your cortisol levels will be high, GH level will be
Resistant state, so growth hormone level will be higher.
high. So that may be beneficial, but IGF-1 will be low.
Undernutrition.
Yes.
Steroids may be low because undernutrition.
Vitamin D will be low. And cortisol will be high and estrogen will be low. So overall, I think there's not much doubt that if you are malnourished, plus your protein is less, your calcium is less, phosphorus is less, so matrix component, mineral component, everything will be low. So they will have a lower bone mass in that